Today to take us through is Dr. Kimani Kahaki, our senior lecturer. I know most of us have had a lecture or gone through her hands, and also learned one or two things about retinoblastoma, which we all know about. But I would like to welcome her very much to start us off this evening. Daktari, karibu.
Good evening, everyone. Welcome to today's presentation. I hope you will find it interesting, and I hope we can learn a thing or two about refractive laser surgery. So I'm going to start sharing my screen right away. I hope you can see my screen.
Yes, we can.
Okay, so this evening we are just going to have a brief look at decision-making in refractive laser surgery. Laser surgery has been available in Kenya, I think now for the last 16 years, because I think the first person to introduce it was Dr. Joshi in the year 2005, if I'm not mistaken. And I would like to start by going through a brief history of refractive laser surgery, because it has been a long and interesting history. So just a brief mention of the historical background. So the first research and invention of excimer laser was between the year 1973 and 1983. And actually the people who came up with excimer laser, they were not medical people. They were working at the IBM Research Center in New York. There were those three gentlemen. And in 1987, that is when the first photorefractive keratectomy was done in New York by S. Trockel. In 1991, there were the first two ophthalmologists to perform Lasik surgery were in USA. So between 1987 and 1991, whatever little refractive laser surgery was being done was photorefractive keratectomy. Then with the introduction of the keratome, then it was now possible to do Lasik. And in 1995, that is when photorefractive keratectomy received approval, FDA approval in the US. And in 1996, so shortly later, Lasik was approved. And in the year 2001, that is when the femtosecond laser was introduced in refractive surgery. And there is also what is known as the wavefront technology, which was approved, and it was customized with the goal of better vision than with glasses or contact lenses, because the previous refractive laser surgeries had the aim of restoring a patient's vision or a person's vision to the best corrected vision. But with the wavefront technology, it aims to achieve even better than best corrected vision. And by the year 2016, over 40 million refractive laser surgeries had been performed globally. And actually by the year about 2018, there were about 20 million refractive laser surgeries being done annually. So it has gained a lot of traction globally, and this is mainly because of its track record of safety. So I'll just briefly mention the methods that are used in refractive laser surgery. So the two broad categories are the photorefractive keratectomy, popularly known as PRK or surface ablation. And then there is also the Lasik, which is laser-assisted in situ keratomileusis. And both surgeries are very similar Actually, what the laser does is exactly the same. It's only that in Lasik, a flap, an anterior corneal flap is created, and the flap is lifted. Laser is done on the stromal bed and the flap repositioned. Whereas in photorefractive keratectomy, it's only the epithelium that is removed. The refractive laser is done, and because of the raw area left, then a bandage contact lens is applied and stays in place for about 7 days. So basically what the laser machine does is exactly the same. However, there are a few differences between the two methods. There are the pros and cons of each of the methods. And if we look at photorefractive keratectomy, one of the biggest pros or advantages is that there are no flap complications. And also, as we have seen from the history, it has a longer track record than Lasik. So it's been proven to be quite safe. It is also easier to perform. So the learning curve is not as steep as in Lasik. And actually, it is recommended any refractive laser surgeons who are just starting off, probably this would be the method to use. And also refractive surgeons who are not doing high volume, this probably is a safer method to stick to. It is also the method of choice for thin or irregular corneas with high myopia or astigmatism. And this is because with the photorefractive keratectomy, the amount of tissue that is chipped or taken out of the cornea in order to change its curvature is less than laser-assisted LASIK. And the downside is that it is associated with more post-operative discomfort as well as a pain. And also it has a longer recovery period, which means that once somebody undergoes PRK, then they will be out of work for a longer period than LASIK. Then it also has a higher risk of corneal haze, and this is especially for high refractive errors. For LASIK, the advantages are that it is associated with less post-op discomfort and pain. It has a faster visual recovery. In fact, we've seen patients, you do LASIK today, and by tomorrow they are up and about. In fact, there is one pediatrician, we did their LASIK, we told them, no, tomorrow don't drive, come in for your post-op review, let somebody bring you, and he didn't turn up. And when we called him, he was busy doing rounds, and he told us he had started doing his rounds at 4 a.m. Then the downside is that there is risk of flap complications, and these can be they can be quite difficult to manage sometimes, and they may take away the benefits of the improved vision that the patient is expecting. They are also not recommended, it's also not recommended in people with high risk of eye injury. So for example, like rugby players or people who are in contact sports, boxing, and such like activities, because if a strong enough force is applied to the eye, even many years later, the flap can still become dislodged. It also has a higher chance of dry eye and also a greater risk of poor night vision. Many patients experience poor night vision after laser because of when it is dark, the pupil becomes bigger, and sometimes the pupil is so big it may even be beyond the area where the laser was done, and this causes aberrations that could interfere with night vision. The third method is the small incision lenticule extraction, known as SMILE, and it was originally called femtosecond lenticule extraction, or FLEX. I don't think this is yet available in Kenya. It has gained a lot of traction in the West because of the quick recovery, and also it is sometimes it can correct higher levels of refractive error than even LASIK or PRK. And just to mention, because people like, especially patients will ask, so how does this laser work? And the beauty with refractive laser surgery is that it just works on the cornea. Nothing inside the eye is touched, and it simply works by changing the curvature of, or the radius of curvature of the cornea, because we know that the cornea is a curved lens, and if you change the radius of curvature of a curved lens, then you change its refractive power, and that is simply how laser works. Now into pre-op considerations. One of the things I want to start by saying is that refractive laser surgery is not for everyone. And many times patients will come for Pre-Lasik assessment and they'll go away disappointed because they will find, for one reason or the other, they do not qualify. One of the critical factors to consider is age. And usually you do not want to do refractive laser surgery on a person who is less than 18 years old. The main reason is that their refractive status may still be changing. And so you might do the refractive surgery, and then a year or two later, the person comes and they are very unhappy because they are no longer seeing as well, simply because their refractive status has changed. Also, you don't want to do laser surgery in patients who are over 45 years old, although this is not it is not an absolute contraindication, as we will see later. And the main reason is because already these are people who are going into presbyopia. And so even though you may be able to correct their distance vision very well, they may still need glasses for reading. And what you will find is that patients who are seeking refractive laser surgery are patients who are, most of them are people who are looking for perfection. And so anything small that will not give them perfection may make them quite upset. Then the refraction status is also very important. And one of the things you want to take into consideration is that the refraction should be stable for at least 1 year. And it should not have changed by more than 1 diopter in 1 year. Initially, they used to say that refractive laser surgery should only be for people who have myopia of -6 diopters. Then it went to -8, but now there are even people who are doing even up to -12 diopters. But the thing to note is that the higher the refractive error, the higher the risk of complications, and especially haze and ectasia post-surgery. So for astigmatism, up to 5 diopters, maybe 6 diopters if you want to push it. Hyperopia, maybe up to 6 diopters. And one of the things to note is that refractive laser surgery is not as good for hyperopia as for myopia and astigmatism. Because you remember in hyperopia, you will be trying to stiffen the cornea. And to stiffen the cornea is not as easy as to flatten it. The cornea structure is also very important to look at, and so that is why you will always carry out topography, pachymetry, and keratometry, and all these have to be normal, because in doing this, then you will be able to find out whether the patient might be having keratoconus or pellucid marginal degeneration. Because in these conditions, if you go ahead and do refractive laser surgery, it will worsen the situation of the patient, so much to the extent that they might even eventually require corneal graft. You also have to find out about pre-existing conditions. And the things you want to really check out are the presence of severe dry eye, and especially in patients with Sjogren's syndrome and rheumatoid arthritis, systemic lupus erythematosus, because these are the people who are likely to have severe dry eyes. Also, patients with other underlying conditions that might uh, increase the risk of not achieving optimum vision. So patients with glaucoma, patients with diabetes, you have to be on the lookout for those, and those may not be very good candidates for refractive laser surgery. Then it's also very important to take into consideration patient expectations. There are those who will come and they will say, well, now once I do this surgery, I'll be seeing through walls like with a laser beam. And you really have to manage those kinds of expectations. And there are actually patients who you will not even want to touch because of the kind of expectations that they have. If they do not have realistic expectations, then these will not be good candidates. Patients who are pregnant or lactating, those also will not be good candidates. And we have noted that sometimes pregnancy tends to change the refractive status of the eye. And so you would want to wait before going ahead with such surgeries for the patient to deliver, finish lactation, and then you can consider the refractive surgery. Then also one of the most important things is to consider timing, so that if the patient is going to go ahead with the refractive surgery, it is done at a time when they can get time off to allow for recovery. There is this one patient we did, you know, many times you will talk to the patient, explain what the procedure is all about, explain how much time they need to take off. And so there is this guy, we did surgery, and the next time he came in, he was complaining. He was he was actually throwing a tantrum. And the reason was because he went flying a helicopter the next day and he couldn't see very well, and he was saying we had put his life at risk. So this is very important, the timing of the surgery. The patient's temperament is also very important. There are those patients who, even the minute they walk into your office, you know, these ones are uh, patients with an ill temper. And such patients, they will be very difficult patients even after you do refractive surgery for them. And there are times when we have actually turned away patients just because of their temperament. Then also to remember that there are other options for correcting refractive errors, including intraocular Collamer lens and multifocal intraocular lenses. And sometimes this may be a better option for a patient rather than refractive laser surgery. This is one of the commonest questions we get: what are the risks? And there are many people who would otherwise consider refractive laser surgery, but when they hear the tales out there, usually from people who have no idea about refractive laser surgery, then they will just cower and never even step into a hospital, even just for assessment. Um, as I had mentioned before, refractive laser surgery has been in use now for decades, and it has a proven track record of its safety margin. However, as we keep telling patients, there is no surgery in this world that is 100% free of any risk or free of any complication. In fact, we keep telling them, even when you pierce the ears just for earrings, you can get complications, infection, and keloids. So even laser surgery does have its own risks. Most of them are not sight-threatening, but they can reduce, they can take away from quality of life. Dry eyes is almost 100%, but as the eyes recover, this gets better and better. And usually by 3 months, most patients will have recovered from the dry eyes, but some it could last even a year, some even a lifetime. Photophobia is also another risk, and that's why even after the surgery, the patients get dark glasses, because especially the first couple of days and weeks, photophobia can be quite a challenge. And so like for patients who are already photophobic, and now they go ahead and do their refractive laser surgery, it may even exacerbate the photophobia. And this is something that we always make our patients aware of. There is also the risk of residue refractive error, either due to undercorrection or overcorrection. And the higher the refractive error, the higher the risk that one may run into residue refractive error. And these are situations where you have aimed for full correction, but the patient doesn't achieve the full correction. And for this reason, they may require retreatment or enhancement, as we call it. There is also the risk of reduced contrast sensitivity or contrast vision. So images do not appear as sharp as they used to appear. So when you take the vision, they may even be 6.5, but they're still saying things are not sharp. So that is when you have reduced contrast sensitivity or contrast vision. As I mentioned earlier, there is also the risk of reduced night vision, and especially if the treatment, the zone treated on the cornea is very small. And normally we will treat between a zone of 6 to 6.5 millimeters. And if a smaller zone is treated on the cornea, then the risk of reduced night vision is higher. Then there is also the risk of higher order aberrations, which include glare, halos, starbars, ghosting of images, and this can be quite disturbing, but usually this tends to improve over time. For LASIK, as I mentioned, there is the risk of flap complications, which could include either the flap getting cut completely or what we call a free cap. You can also get buttonholes. You can also get a ragged flap, and you can also get a partial flap. And all these can can be quite a nightmare for the surgeon. Sometimes they may not affect the vision much, but in some cases, they may be the reason why the patient doesn't achieve the full correction. Then, as I mentioned, for photorefractive keratectomy, this one is standard pain and discomfort, especially for the first 2 days until the corneal surface is epithelialized, then the pain and discomfort will subside. Then there is also the risk of regression. This is the situation where you have achieved very good post-op vision, and then a couple of months or years down the line, the eye starts regressing towards especially myopia, and this may require retreatment. And the higher the refractive error, the higher the risk of regression. Usually when it is under -6 diopters, the risk is not so high. Probably you're talking of 1%, but as the refractive error increases, it could go as high as even 5% of patients who have had refractive laser surgery requiring retreatment because of regression. I just want to share outcome of refractive laser surgery at our center, that is at Eagle Eye Laser Center. So we reviewed patients who had been operated between 2010 and 2016, and we got 400 patients, and with 785 eyes, 58% of whom were female, with a mean age of 34.4 years. The pre-op spherical equivalent refraction ranged from plus 4.75 diopter spheres to minus 10. So the pre-op spherical equivalent ranged from plus 4.75 diopter spheres to minus 10 diopter spheres. Lasik was performed in 61.3% of the cases and photorefractive keratectomy in 38.7% of the cases. 4.1% also had Pre-Lasik. Pre-Lasik is where you undercorrect one eye, especially in patients who are above 40, who will soon be going into presbyopia. And so when you do Pre-Lasik, you delay the onset of the presbyopia so that they can at least enjoy their vision for a couple of years before they need to use their reading glasses. And usually we will do Pre-Lasik in the non-dominant eye. At 6 months post-op, 85.6% of the patients achieved a vision of 6/6 or better, and 98.1% achieved a vision of 6/12 or better. The complications, we found complication in 7.6% of the cases, with the residue refractive error and regression being the leading one at 3.1%, and persistent dry eye at 2.7%, and persistent haze at 0.7%, and optical aberrations at 0.5%. I think I forgot to mention one of the most feared complications for refractive laser surgery is corneoectasia. And we got one patient who developed corneoectasia among the patients that we reviewed. Many times we think that patients feel it's only in public hospitals that patients don't come for post-op follow-up, but we also found that post-op follow-up, even for our patients, was not that good. And remember, these are patients who we will even call on the phone so that they can come for their follow-up. But despite that, we only, at 1 week, the number of patients who came for follow-up was 89.4%. At 1 month, it was 67.5%. At 3 months, 50.6%. And at 6 months, 35.7%. So even the vision that we were looking at 6 months, it was only in the 35.7% of patients who came for follow-up. So I'm just going to share a few case reports of some of the interesting patients that we have done refractive laser surgery. So let me start with this 20-year-old girl who came to us for Pre-Lasik assessment in January 2011. We had just started doing our refractive laser surgeries in October 2010. So we were still very new at this. And this girl, she was a professional swimmer. So, and her vision was counting fingers. I don't know why, I don't know who is drawing lines on my screen. But anyway, it writes her team and then draws a green line. But let's go on. So her vision was counting fingers at 2 meters in each eye. So you can imagine what a challenge it was for her, being a professional swimmer and the vision being this bad, she can't swim with her glasses. And when we refracted her, she was coming to 6/6 with -6 and with diopter spheres and -2.5 cylinder in the right eye, and 6/6 with -4 diopter spheres with -1.5 cylinder in the left eye. and her refractive status had been stable for a year. So you can already see this is quite a high refractive error. When we are calculating how much correction to do, we add up the total refractive error. So like for the right eye, we are looking at 8.5, and for the left eye, we are looking at 5.5. And this is how her topography looked like. So this is one of the most important things that we look at when we are considering whether somebody is a suitable candidate for refractive surgery or not. And it's not just enough to look at the central corneal thickness, but most important, you look at it in relation to the refractive error, because the higher the refractive error, the more the tissue of cornea that you will need to take away to change its curvature. So her corneas were quite good. You can see they are quite even, and the corneal thickness is also quite good at 512 and 515. We look at the thinnest location, so 512 microns and 515 microns, that is very good. But when you take her refractive status into consideration, then her corneas we felt they might be left too thin. And we initially suggested photorefractive keratectomy because we felt this would be much safer for her. But the patient was not very keen, because we will always take the patient through what to expect, whether it is after Lasik or after PRK. And when she heard about the pain and the discomfort, she wasn't too keen. Normally, when we do Lasik, we make a flap that is 130 microns thick. And when you're calculating how much stroma will be left behind after you do your refractive surgery, we include the thickness of the flap. Or when you consider how much will be left, you take away you minus the thickness of the flap. So normally we do a flap of 130 microns, and when we calculated with 130 microns, we found the cornea would be left too thin. But fortunately that year, we have a German colleague the one who trained us to how to do the refractive laser surgery, and he was visiting, and he came with a keratome that can do a 110 micron flap. And with that, it was possible to leave her cornea thick enough. And postoperatively, she was very happy, and she achieved uncorrected vision of 6.5 in each eye. But 6 years down the line, she came back. She wasn't happy with her right eye because the vision had dropped. And we suspect her right eye is the dominant eye, and that is why she was really noticing it, and she was not happy. And on refraction, the vision improved to 6.5 with -1 diopter sphere and -0.75 cylinder in that right eye. But the challenge was that now the cornea that had the cornea that the thickness of the cornea that had remained is now 395. And 395, you don't want to touch. If you touch, there is a very high risk that you could go into ectasia. So I think after some discussion, we agreed that sometimes best is the enemy of good. And so far, she is managing, and it has remained at 6.9. The second case I want to share is a 30-year-old male who came to us in December 2019, and his vision was 624 in the right eye, 636 in the left eye. He had lost his glasses, and he was saying this was like the sixth pair he had lost in a short while, and he really did not want to go back to glasses. On refraction, you can see the refractive error is in that high, -1.25 diopter spheres with -0.75 cylinder. So about a total of -2. The cornea thickness was not that fantastic, 476 microns and 489 microns, but because the refractive error wasn't that high, he qualified for laser surgery, and we did, actually he would have qualified either for LASIK or for photorefractive keratectomy, but after the discussions, he settled for photorefractive keratectomy, which was carried out in January 2020. But even immediately on his first post-op review, he was already not happy with the vision in his right eye because he was saying it's blurred. And even 1 month post-surgery, the visual acuity in the right eye was not that good. It was 618, but the left eye was 65. And the right eye improved to 66 with minus 1.75 diopters. So it's almost like no treatment had been done. And yet we know we had put in all the parameters correctly. So we advised him to wait 2 months and we see what would happen. But even in 2 months, the vision still had not improved that well. So he underwent enhancement. So that is retreatment of the right eye in March 2020. And with that, the vision improved to 6.5. And by the time we saw him last, his vision was 6.5 in September 2020, and he was quite happy. So this is a case where sometimes even when you aim for the best, you still end up with undertreatment, and you may have to repeat. And when we repeat, we always look at the corneal thickness, and we have to be sure that even when we retreat, the cornea will still be left strong enough. The third case I'd like to share is a 45-year-old businessman. As you remember, we started by saying that patients who are above 45, not very good candidates for laser surgery. But this particular gentleman was really, really tired of his glasses, and he was really looking for a solution. His vision was counting fingers at 2 meters in each eye, and refraction was shown there, minus 4.25, with a minus 1 cylinder in the right eye. Actually, in both eyes, they were exactly the same. But we found that for him to be able to read N5, we had to add plus 1.5 diopter spheres. So we explained to him that even if we correct his distance vision, he may still need reading glasses. But he agreed to Pre-Lasik of the left eye, which was his non-dominant eye. And we went ahead and did the laser surgery in November 2019, and he had Pre-Lasik in the left eye. His last review was in March 2021, and he is very happy with a vision of 6.5 in the right eye and 6.6 partial in the left eye, but able to read N5 without any correction. His only problem is an occasional dry eye, and one of the other reasons why older patients are not very good candidates for refractive laser surgery is that they are at higher risk of dry eye, and they are also at higher risk of higher order aberrations that we mentioned. This case, case 4, was a very interesting one because this was a 56-year-old male. He said he was a barrister. He was from the UK, and he was doing some work in Africa, and he decided to come to Nairobi because he was looking for a center where he can have laser surgery, refractive laser surgery done, because he said in London they had told him he was too old to have laser surgery. And the reason why he said he really wanted refractive laser surgery is because it was critical for him to be able to see even without glasses, because his main work involved collecting evidence on crimes against humanity. So he would go to areas which may not be very safe. And so he said if he happened to lose his glasses, he would be like a sitting duck. And so when we examined him, his vision was 360 in each eye. and he would achieve 6/6 vision in each eye with -5 diopter spheres with -2 cylinder, giving you a total of a refractive error of -7. And he would read N5 with an add of +2. And we suggested to him that maybe he ought to consider multifocal intraocular lens with clear lens extraction. He didn't want that. And he also wanted full correction in each eye. And he said he is happy to wear reading glasses. So he underwent LASIK in May 2014, and his post-op vision was 6/5 in each eye, and he was happy to use readers of +2, and he was very happy. So even though we say older patients are not good candidates, sometimes you may make an exception. But one of the things that we made sure is that we did his biometry, and we gave him his records. We did his biograph and gave him his records in case for the future when he would need cataract surgery. Because once you have done refractive laser surgery, then doing your IOL calculations in biometry can sometimes be quite tricky. The last case, this actually has been our nightmare case. Sometimes things don't always go the way you'd want. And this was a 34-year-old female, a doctor, and she came to us for Pre-Lasik assessment. Her visual acuity was counting fingers, 3 meters, both eyes, and her refraction was -5.75 diopter spheres with a -1.75 cylinder in the right eye, giving a total of 7 diopters in that eye, and -4.75 with a -5 cylinder in the left eye, giving a total of 9.75. So this was already on the borderline. But when we did her topography, everything looked very good. Corneas were nice and thick. And we said, this is a candidate that we can do photorefractive keratectomy. And usually when you do photorefractive keratectomy for high refractive errors like -6 and upwards, usually we will apply mitomycin C solution on the bed, or after doing the photorefractive keratectomy, we will apply the mitomycin C solution. The higher the refractive error, the longer you leave the mitomycin solution, then rinse it off before applying the bandage contact lens. And this is what we did. And 1 month post-op, her visual acuity was 6/6 in the right eye, 6/9 in the left eye. I'm going to share a number of topographies as we see the progression. So this was her pre-op oculizer, central corneal thickness of 556 in the right eye, 553 in the left eye. We rarely see this kind of corneas because most of our patients at most will be 510, 520. Most of them will be below 500, but still qualify for laser surgery. I don't know whether you notice the left eye, there was something that probably we should have taken note of. And you can see that butterfly-like pattern, although there is no thinning, but already probably that was a red sign, a red flag. And she came to us a year later complaining of reduced vision, especially in the left eye. The vision had dropped to 660. And if you look at the topography, you will see the cornea on the left eye. The inferior part of the cornea is quite steep. There is steepening of that inferior part of the cornea. And when you look at the pachymetry, the left eye is 396 microns. And lo and behold, we were dealing with ectasia post-refractive surgery. And we went ahead and did cross-linking for that left eye. Her right eye still had fairly good vision, and she felt she could cope without glasses. And so we kept an eye because we felt anything could happen. And so every year she would come in for topography. 2014, everything is good. Vision in the right eye, 6.6, left eye still 6.18. June 2015, still stable. Vision in the right eye, 6.6, left eye, 6.18. And then I think she felt comfortable and was no longer coming for follow-up. Then 4 years down the line, she comes back because vision in the right eye has dropped. And lo and behold, when we do the topography, we find that she has developed central corneal thinning and some stiffness on the inferior part of the cornea. And the right eye had also developed corneoectasia. So we advise her to have cross-linking for that eye, which she underwent in April 2019. But now she has had to go back to using glasses, which don't give her as good vision as she used to have prior to the surgery. And she's also intolerant to rigid gas permeable contact lenses and also to hybrid contact lenses. So she is extremely unhappy. We have given her the option of an intraocular Collamer lens, but she has not yet taken up this option, and we don't see her a lot. She doesn't come to us anymore. So things can really go south. Things can really go south even in the best of situations. And so in summary, refractive laser surgery can be a wonderful and permanent solution for refractive errors. The decision to have refractive laser surgery is very personal. So we never tell a patient when they come that you should have refractive laser surgery. We wait for the patient to ask us. Patient selection and counseling is very important because this will prepare the patient for what may come ahead. Pre-op assessment is critical in decision making, and so even for a patient who is interested in laser surgery, we tell them the first step is to have assessment to decide whether they are a suitable candidate or not. Refractive laser surgery has no 100% guarantee. This is like our mantra. It is not 100% guaranteed. Things could go wrong. Most initial side effects subside with time, and they will rarely affect the vision in an appreciable manner. And long-term follow-up is important. Let me mention this because sometimes, especially for high myopes, just because now they see perfectly, they forget that they are still at the same risks as high myopes, especially peripheral retinal degeneration and detachment. And so they still need to have their annual fundoscopies to look out for this. And also to remember that there are other solutions for those who do not qualify for refractive laser surgery. And that is the end of my presentation, and thank you very much for listening.
Thank you very much, Dr. Kimani. That was a very enlightening presentation. There are a few questions on our chat, so I'll just go quickly through them. There's a question about what is Pre-Lasik and how does it differ from PRK and LASIK? I don't know.
Okay, so Pre-Lasik, there are not many people doing Pre-Lasik now because Pre-Lasik, what it means is you remove the epithelium, you do the laser, and then you put back the epithelium. So it means you have to be very careful in removing the epithelium so that it is a continuous layer so that you are able to put it back. It is said to have less discomfort post-op than PRK. but they'll still experience some level of discomfort, and you still need to put a bandage contact lens. And let me also say that whether it is PRK, Lasik, or LASIK, ultimately they achieve the same level of vision. The visual outcome is very comparable in all of them.
Okay. You had mentioned something about IOL calculation being a bit challenge after laser surgery, and there is a question on how is IOL calculation done in post-LASIK patients.
Actually, as I mentioned, it's quite tricky. In fact, there are always new formulas coming up on how to calculate the IOL power, and one would probably need to Google to see what is the latest formula to use. But it's important to know, because of the change of the corneal curvature, the radius of curvature of the cornea, and the axial length remains the same. That is what makes it a bit tricky.
Okay, the right thing.
And many times, if you
Well,
use the readings as they are, then your IOL calculations may not be very accurate. So you may need to do some adjustment.
okay.
And so, like for older patients, we always make sure we do their biometry before we do their laser surgery.
Okay. Also, there's another question. What is the effect of presbyLASIK on stereopsis, especially for distance? A number of patients are unhappy.
For the patients that we have done Pre-Lasik, I've not found anyone with an issue of stereopsis. The trouble is when you get patients who have codominance, who don't have any one eye that is dominant, then those are the ones who sometimes may have some level of difficulties. But as in terms of stereopsis, I have not come across any patient complaining about stereopsis. And usually what you will notice, even after Presbylasik, the distance vision is still pretty good. For most of our patients, it is really below 6.9 partial, even in the eye that we do Presbylasik.
Okay. I hope that answers that question. Maybe if, unless there's someone else with some contribution. You had talked about cross-linking after the LASIK surgery, but there is a question from Fazal. Is there a role for doing cross-linking prior to LASIK for high myopia to prevent regression?
Ooh, okay. Let me say that we have not really found a good method of preventing a regression. But there are a few cases where we have found if you do the full correction, then the corneas will be left borderline with a risk of ectasia. And there is probably one or two patients who we have combined cross-linking with refractive laser surgery. So we will do the refractive laser surgery. Those are patients who will have a photorefractive keratectomy, and then at the same sitting, do cross-linking. And for such patients, we have not found any ectasia post cross-linking, post refractive laser surgery.
Okay. Also, there is a question on what is the minimum corneal thickness that can be safely left post refractive surgery?
They say 290 microns, but we always prefer not to go below 300. It has been found 290 microns is safe, but we prefer not to go below 300.
Okay. And then Dr. Owen asks if you assess for dry eye before refractive surgery, as it was mentioned as one of the risk and also complication. Yeah.
We do not do any assessment per se, other than the routine examination, but the most important thing is the history from the patient.
Okay.
There are one or two patients who have come with even history of dry eye, but they really want the surgery. They say, I'm already using the lubricating drops anyway. And we've gone ahead and done the surgery, and it has not made their situation any worse. But these are patients who we have really counseled and talked to, and they know what to expect. But routinely, we do not carry out any tests for dry eye, just the history.
Okay, and I think our final question for today is about your youngest age criteria for considering LASIK. I think this wanted specific for LASIK.
I think probably for us, the youngest we have done is 19-year-old. As I said, you do not want to do patients who are below 18 years old. Even 18 years old, when they come, we'll tell them, wait a year, let's see whether things are stable. So for us, the youngest we have done is 19 years old.
Thank you very much, all of you, for your questions. Dr. Kimani, thank you very, very much for the presentation. There are several messages of comments on the good presentation.
Thank you.
Thank you very much, Dr.
Thank you. Thank you. Much appreciated. Thank you. Thank you,
Okay.
everyone.
So for this evening, the presentation has been made possible by our sponsors, the Novartis company, and I would beg your indulgence. We give them a few minutes to give us a presentation on some of their products before we close up for the day. So I'll invite Charity Ciele to share her screen and also talk to us this evening. Karibu, Charity.
Thank you so much, Dr. Kalu. So I'm Charity Ciele from Novartis, and thank you, Dr. Kimani, for such a powerful presentation. So Dr. Kalu, are you able to see my screen?
Yes, we are able to see your screen. Go ahead.
Okay, thank you so much. With me, I'm going to take us through use of Nevanac in the management of pain and inflammation post-cataract. So Nevanac, it's an NSAID, nepafenac ophthalmic solution suspension, 0.1%. So that's the presentation of Nevanac. What Nevanac is, it's an NSAID, a topical NSAID containing an active substance, nepafenac. So for Nevanac, it comes as a prodrug, but once it is instilled into the eye, the intraocular hydrolysis converts to the active form Amphenac. So it's 0.1%. It's a sterile yellow to light yellow to light orange uniform. It has a pH of 7.4, so it's comfortable to instill. Nevanac, it's for two indications. It's approved for the two indications. One, for prevention and treatment of post-operative ocular inflammation and pain. And the second one is for prevention of cystoid macular edema in patients with diabetes following cataract surgery. Mode of action of Nevanac. Nevanac comes as a prodrug, but once it is instilled into the eye, the intraocular hydrolysis converts to the active form, which is Amphenac. Nepafenac and Amphenac inhibit both COX-1 and COX-2 enzymes that are responsible for prostaglandin production. Both nepafenac and Amphenac, they block the inflammation-mediated breakdown of the blood retinal barrier that contributes to plasma extravasation and edema. So what Nevanac offers is a novel prodrug structure. It optimizes activation. What do I mean by optimizing activation? Upon ocular dosing, the nepafenac metabolized by the intraocular tissues to the active form that is Amphenac. It has a target-specific efficacy. Nepafenac, once it is converted to the active form, which is Amphenac, so it acts at the point where inflammation or pain can occur, either from the cornea, iris, ciliary body, choroid, and to the retina. Also, Nevanac, it minimizes toxicity because ocular surface complications associated with conventional NSA therapies may be minimized because drug Nevanac, which is the drug, rapidly distributes into anterior and posterior segments. So in terms of human aqueous concentrations of NSAIDs, so we have that presentation. We have different NSAIDs. We have Promfenac, Ketorolac, Amphenac, Nepafenac, and the inactive, which is Nepafenac, inactive form, and active form, which is Amphenac. So after instillation to the eye, so it's been found that commercial Nepafenac 0.1 suspension, which is the Amphenac plus the Nepafenac, demonstrated significantly greater ocular bioavailability of drug than either Ketorolac 0.24 or Promfenac 0.09 solutions. So in terms of the dosing, we have the dosage for Nevanac, both for non-diabetic patients and for diabetic patients. So for non-diabetic patients, which is given for prevention and treatment of pain and inflammation post-cataract, so the dosing for Nevanac, will give it 1 drop 3 times daily in the affected eye. And you have to start it a day prior surgery, on the day of surgery, and 14 days after surgery. That is for the non-diabetic patients. And also an additional drop can be given 30 to 120 minutes prior to surgery. And for reduction in risk of postoperative macular edema associated with cataract surgery in adult diabetic patients, a drop is given 3 times daily in the affected eye. So you begin a day prior surgery, on the day of surgery, and up to 60 days after surgery. And also an additional drop can be administered or given 30 to 120 minutes prior to surgery. So those are the dosing for non-diabetic patients and for diabetic patients. So what Nevanac offers to your patients? So we have some summary, and because of its unique prodrug structure, Nevanac is activated in the target ocular tissues and is metabolized by the intraocular hydrolysis, delivering superior inflammation suppression. Nevanac also has a target-specific efficacy. Once it is converted into Amphenac, which is the active form, right where inflammation can occur, either in the iris, ciliary body, choroid, retina, and also the cornea. Nevanac suspension delivers superior prostaglandin inhibition, resulting to excellent anti-inflammatory efficacy. This leads to highly effective post-cataract.
Charity, we cannot hear you. Charity, we are not able to hear you. Hi, Charity, we are not hearing you. Hi, Charity. We seem to have lost you.
Hello. Hi, Dr. Kalu.
Hi, we can now hear you. We had
Oh, you
lost
can't hear me?
Yes, we had lost you a
Oh,
while there as you are doing your summary. So maybe
okay.
you can just give a verbal summary without the presentation so that you finish.
Okay. Sorry for that. And as I was doing my summary, so I had mentioned the key messages for Nevanak. Are you able to see my screen?
Yes, we have.
Okay, sorry for that. So I was saying because of Nevanak unique product structure, it is activated in the target ocular tissues and metabolized by the intraocular hydrolases, delivering superior inflammation suppression. Also, Nevanak suspension, it has a target-specific efficacy. So what do I mean by target-specific efficacy? Nepafenac is converted into Amphenac right where inflammation can occur, either in the cornea, iris, ciliary body, choroid, and also the retina. Nevanak suspension delivers superior prostaglandin inhibition, resulting to excellent anti-inflammatory efficacy. This leads to highly effective post-cataract inflammation control. Nevanak also has been proven safety and tolerability profile. It has a safety and tolerability profile. What do I mean by safety? Because Nevanak, it has a pH of 7.4, so it's comfortable to instill because it doesn't cause burning sensation and stinging. So also with the compliance, patients do comply because it doesn't sting. So for Nevanak, for your non-diabetic patients, or also diabetic patient for cataract, so you can comfortably prescribe Nevanak. So I can take any question if there is. Dr. Kalu.
Thank you, Charity.
Thank you so much for your time.
Thank you very much. So I would like to thank all of us for having been present today for our CME. Thank you for making it a success. Thank you, Charity and your team from Novartis for helping us sponsor today's session. There is a question before we leave from Mingaine asking if anybody uses NSAIDs exclusively post-cataract surgery locally. Maybe anyone who does that can give Daktari a message so that he is also able to get an answer to the question. Thank you again, Dr. Kimani, for the wonderful presentation. I believe we have all learned quite a lot today evening, even as we continue with giving our patient the best of care we can. I would like to remind us that we have an upcoming African Retina Scientific Conference on 4th and 5th. So endeavor to be there so that we continue with this learning. And our next CME will be in June. The topic and presenters will be communicated in due course. Thank you for being with us until this far. I think I'll bring the session to an end. My name is Dr. Agnes Idzakalu, and I hope all of you have a good night. You are free to leave at your own pleasure. Thank you.